Welcome to Discover Health, a White Mountain perspective. I am your host, Dr. Tom Barela. And once again, we're going to explore some issues relative to essentially everybody, because today we're going to talk about the finances of healthcare. I know that nobody really worries about the costs of healthcare. That's probably not true. And today we're going to talk about the finances of the system, some alternatives that have arisen through the years, and hopefully a perspective that everyone can understand their health care. And to do this, we've invited in Brad Stoddard, who is the administrator of the Sunrise Surgical Center up in Lakeside. And he has a perspective, of course, as an administrator, involved closely in the finances. And I would say welcome to our program today, Brad.
Thank you. Glad to be here.
Well, I'm glad that you're here too, because you, as someone who's involved with actually getting paid for healthcare rather than me on the consumer side, probably understands the system a lot better than I do. And I would say let's start and talk a little bit about the money systems, and then I know we want to talk about a surgical center and how that arose through the general concepts of the system. So let's start by talking about charges, because it's all over the news.
Yeah, you bring up a great point about charges, and a lot of people don't understand that what is charged isn't necessarily what you pay. A lot of people in the news read about the Tylenol that's $12 or the Band-Aid that was $10, and that's not what you actually pay in the end. How it works with a hospital, I used to work at a hospital, is we would go through and anything that we would use, a Band-Aid, or if a nurse came in more times, we would charge for that. We would charge for the bed. We would charge for how severe things were. If a cut was open a certain centimeter, that's a different charge if it was at 8 centimeters versus 4. And each thing has a charge associated with it. But the charges isn't what you pay. The charges is kind of a wish list of what the hospital would love to get. But how it works is, if a hospital charges $10,000, then what happens is, based on the contract they have with the payer, that affects it a lot because they have allowable charges. So let's say that Tylenol that was charged $12, in actuality, maybe the hospital charged $12, but the payer only allowed $1 for that. And so what happens when you look at your explanation of benefits, or EOB, you see that it goes from a really high number, a discount by the insurance, and then you're left with something at the end.
And of course, the real question is, why charge
That's a great
$10 for the aspirin? I know that an aspirin from the bottle doesn't cost a full $1, but there are other costs associated with giving it actually in the hospital.
Right, and so sometimes, like Blue Cross Blue Shield or United, all your large payers, Medicare, Medicaid, they'll have a set rate. But sometimes there's a payer that they do a percentage of charges. And so that $12 pill, maybe they have a contract that they get 75% of it. So that's why hospitals kind of charge inflated, because sometimes the payer will pay a little bit more than they should.
Yeah,
it's kind of a dance. It's kind of a dance.
Sometimes. And I know that in the 70s and 80s and even in the 90s, a lot of them were a percent of charges payment to hospital systems, and that's why they had high charges.
Yep.
Nowadays, of course, it seems like Medicare drives a lot of what actually a hospital pay, and we all recognize that except when you don't have insurance.
Yep.
And you get
huge
the bill. The bill.
Right.
Okay.
And luckily what's happening in legislation right now is a lot of congressmen is starting to take a stance where, you know what, people are getting charged out of pocket high rates. And so there's actually legislation right now that they're working to lower that cost for the consumer.
Okay, so we'll get to that in a second, because that's good. Now tell me about costs. I mean, you obviously run a surgery center, so costs is different than charges.
Absolutely. So costs are what the real cost is. That back to the Tylenol, that's expensive. Maybe it cost a nickel instead. And so what you have to do is all healthcare companies are trying to figure out what's the most they can get paid and keep the cost as low as possible. And so the cost is at the last end of it. So you got your charges, and then the insurance company will affect it and give you a discount. And then at the very end is the cost of it. And so healthcare providers are trying to get something above that cost.
Right. Well, everybody needs to make a profit.
Right. And sometimes, though, it doesn't happen. You have people who come in who don't pay, or maybe, like you said, they don't have insurance, but it's an emergency. And so they're seen anyways. So there's lots of different things that can affect what somebody pays at the end of the day.
Okay, that's the payment. But the cost is really important because that's what you really have to do to provide the service.
Right.
You know, and I think that that's important that people realize that everybody's employer has to make a profit, otherwise nobody makes an income.
Absolutely.
Okay. And I think probably the issue is more so right now with the drug companies because it's incredibly high.
Yep. And that's a whole other thing. Like you said, everybody's trying to make a profit, and everybody wants to pay as little as possible for that product. But I think it's starting to change too. I think with the pharmaceutical companies, implant makers, I think everybody's feeling a little squeeze. So I'm optimistic that they'll be able to lower the prices in the future.
That was really good. And so let's go down to the last piece, which is the payment.
Yeah.
Which you alluded to a little bit. Most people really don't decide how much they're going to pay. It's mostly their insurance.
Right, absolutely. So if you are with Medicare, you know exactly how much you're going to pay. Typically, it's 20% of an outpatient, unless you have a supplemental plan. But every single insurance, so like if you have United, how much you pay out of pocket would be different if you were insured by Blue Cross, because every payer has a different contract of what they do. So we've all heard of deductibles, and a lot of people have deductibles now. You know, you've been a doctor for a long time, and I'm sure when you first started out, deductibles were pretty small.
Yeah, they were. I remember when patients first started to have to pay co-payments and how difficult it was to pay co-payments up front.
Right, and that's a great point. So you have deductibles, co-payments, and then I don't know when this started, but then co-insurance cropped up. And what we've seen is this huge shift from the payer, Blue Cross United, to the consumer. And now the high deductible plan. 20 years ago, I don't think anybody was talking about a high deductible plan.
Correct.
But as of right now, the shift is going from the payer to the consumer. And so it makes a huge difference. Obamacare, whether you agree with it or not, it really did alter the face of healthcare. And it changed a lot of the way that people pay. And so people who used to pay a small amount for deductible, all of a sudden they're paying a higher deductible. And so people just have to be aware that as they are in charge of their finances more and more, they have to be aware of there's options out there.
And I think it's important for people to understand that if they have a high deductible or a high or a health savings account, if they receive a bill for $3,000 for a Tylenol, that isn't necessarily even what they're going to pay.
Right. So a lot of people do get upset about what they were charged, and you can just not even look at that, because really what you were charged, it doesn't matter. You have to look on the explanation of benefits, the allowable charge column, and that's what's important, because that's what's going to hit your pocketbook.
So even if you have an HSA, your insurance, but do all people with HSAs have insurance, first cover dollar? I mean...
So I think most of them do.
Okay.
The employer has said, we will work with United. We're going to have a high deductible plan, but you can do an HSA account or a health savings account. And it's really great because if you have that, you can put money in tax-free.
Right.
And it doesn't hit your taxes. And then you can use that money to pay your high deductible plan.
Okay, and that's really good because you still get the advantage of the allowable by your insurance company. So that $3,000 bill for a Tylenol probably is not going to be more like whatever, $10.
Yeah, and then you can use tax-free dollars to pay that bill off.
Okay, great. And this whole healthcare system has given rise to alternate places to receive care. It's given rise to nurse practitioners and physicians' assistants, but it's also given rise to surgical centers. which started when?
So in 1970s, actually 1970 was the first surgical center. And we're kind of lucky here in Arizona because it started in Arizona. There was 2 physicians, surgeons down in the valley, and they just felt like there's a better way of doing surgery. If you've gone to a hospital, you know that you have to park far away. Sometimes it's impersonal. I know they try to do their best, but sometimes it feels a little overwhelming to go into a large facility. And sometimes, too, they would have a 9 o'clock surgery at this hospital, but maybe a trauma comes in, or somebody with a cardiac issue, or a gallbladder that has to be taken out. So their surgery would get bumped. And then maybe it got bumped 2 hours, and then somebody else would happen. And so they felt that they were doing a disservice to their patients. So they started looking around and said, you know what, is there a different way we could do surgeries? And they were the guys that created the first surgery center that was certified in Arizona. And then shortly after that, it kind of spread throughout the entire country.
Oh, and that also affected physicians, because if you schedule a surgery at 9 o'clock, you've scheduled yourself out of something else at that time, so you're sitting around and waiting. So it really was convenient for both the patient and the surgeons.
Absolutely.
And the staff.
Yeah, and so it worked out really good for them, because at a hospital, it's expensive to run a hospital.
Well,
you have a lot of surgeons, you have physicians, you have nurses, and then you also have 24-hour care at the emergency department. And so they have oncology, which is expensive to run. At a surgery center, we don't have any of that. It's Monday through Friday, 8 to 5 typically, and so our cost can be a lot smaller. Back to what you were saying about cost, we can lower our costs, which means that we can offer care at a lower price.
And it's interesting, Loma Linda University learned back in 2000 that it was more cost effective to do surgery at the surgery center 24 hours a day, 7 days a week.
Oh, that's interesting.
That was one of their things at the early cost savings for managed care. But different issue. I think that's a great point. It didn't have anything to do with the quality of medical care.
No, and that's what some people are afraid of. They think, well, the only place to have surgery is at a hospital. And technology, because you think in 1970 is when the first one started,
yeah.
And I'm sure they did very simple procedures back then. But now fast forward 50 years, and we've seen a huge change in the technology and also anesthesia. And also pain management in that time frame. So before they would just do simple procedures, and now they're doing spine, and then they're also doing total joints also. It's very exciting.
Oh, that is exciting. I remember the days when the first outpatient surgeries were done, and we were all scared. Not so much me, because I'm not a surgeon, but a lot of that transition, and it seems like more and more technical things are now outpatient.
Yep.
It's impressive.
And what we're seeing is Medicare, every single year, they add more and more procedures that are okay and allowed in an ambulatory surgical setting. So I think Medicare is starting to see, you know what, if we could have more patients go to a surgery center, then we could save a lot of money. And so typically what I've noticed is, because I came from a hospital, let's say Medicare would pay us $3,000 for a procedure in a hospital. If you go to a surgery center, it's about $1,500. It's about half the cost. So not only are we saving money for the patient because their 20% is less that they owe, we're also saving the system money. You know, a lot of people are afraid of where Medicare is going to be in the next 15, 20 years. And if we could continue this shift from inpatient to outpatient, then we're going to save Medicare a lot of money.
I think that's a great point. Has nothing to do with Medicare, but the medical care. Okay, so let's go through some of the technical things. You have a surgical center. How is your certification? I mean, people like places that are certified.
Right.
Even our auto mechanics need to be certified.
Absolutely. And so we have a company called HHC, and we pay them every 3 years to come in. And what they do is they do an inspection from A to Z, top to bottom, to make sure we're compliant, that we're safe, and that we're effective, and that we don't have any issues. Also, when you open up a surgery center, the state has to come in and make sure that you're safe. And also Medicare, if you're going to take Medicare patients, they'll send somebody out also. So we're just like a hospital. We have a credentialing body that comes in, and they send us somebody, and they make sure that we're good, that we're sure that we're safe. They go through our records. And also the state and Medicare can come in anytime and just make sure we're doing good. So you bring up a good point. You want to feel good that where you're going is going to be a safe place to go.
Well, yeah, I mean, my body,
It's your body.
is important. and so you undergo a very similar certification that hospitals do on a narrower scale, but your criteria for certification are almost identical or are identical?
Yeah, they do. They look at falls, they look at infection rates, they look at different things of how many, have we had any issues? We call them sentinel events, you know, a death. And luckily, we're very fortunate that we haven't had any issues like that. As far as the infection rate, we're actually below the national average. And as far as fall rate, so a fall rate is if a patient falls, and we're below the national average there also. So they set standards, and then we try to be the best we can to make sure those standards are met or exceeded.
And you have internal quality control committees that, just like hospitals do, and stuff, to make sure that you are staying up on things when they do occur, because things do occur. Absolutely.
So what we do is we try to have 2 studies going throughout the entire year. We look at something and say, you know what, this is okay, but can we make it better? And we always have 2 studies going like that, so we're always improving.
Okay, and another thing that I know you didn't mention, but I know you are really cognizant about, is hospitalization after surgery, because I know every surgical facility in the world has actually that potential issue too, is readmission rates and admissions after surgery, complication rates.
Yeah, and that's more and more Medicare is looking at that, because what they're seeing is with some places, they'll have the surgery and then the patient would come back for a complication, an infection or something within 30 days. And they call that a readmission, like you said. And that costs everybody a lot of money because the procedure is done once and the patient should have been fine. And so we're very aware of that also. And luckily we have a really great readmission rate. And so we're aware, and also what we do is, sadly, not everybody can come to our surgery center. There's different people who can't do it because at a hospital, you have everything under the sun to help somebody out. At our place, we try to keep our costs down, so if maybe somebody has a lot of comorbidities, or in layman's terms, just issues, maybe cardiac issues or pulmonary issues, then they're probably not going to be able to come to our center due to safety reasons.
Well, I know that a lot of us, before we have surgeries, have to have clearance by a physician in order to have that particular surgery. And you apparently use that clearance seriously because...
Absolutely. At a hospital, there's a lot more gray where you can maybe try something because you have some backup. With ours, we're very selective of who we can come. And like you said, clearance. And so maybe somebody has had a cardiac issue or a stent. And so the doctor, the surgeon, will say, you know what, before we do it, we need to get cardiac clearance from your cardiologist and make sure you're okay. And then also what we do is not just the surgeon, but our anesthesia provider. We have him or her look at the chart too, and just make sure that both parties feel comfortable that we can do this person in a safe manner. But what's interesting is we just had somebody who was 92, and they came in and they did great. So it doesn't matter on the age, it's mostly if they are a healthy person. And so we do pediatric all the way to really mature people, and we've had great outcomes.
And so you have anesthesiologists that are essentially pediatric oriented, just like big cities do. They have anesthesiologists that do children. I know you don't do surgeries on 2-week-old babies, but I mean, essentially you have people that are cognizant and trained to do all ages. But I think it's important that people understand that from a safety standpoint, the pre-certification is important because you don't have the intensive care unit down the hallway.
Right.
If you have a problem, the paramedics have to come and transfer them into the hospital, and there's a potentially much longer delay because although I know you have the normal resuscitation material and the capabilities of doing emergency interventions and stuff, but I think it's important for people to know why we go through that potentially yucky pre-certification where we go in and say, I'm an 80-year-old, but I'm really healthy, and sometimes you're just not. You
Right.
just don't know until you get sick. So that's important that you guys are cognizant of that. And it's important to know that if you weren't, you wouldn't have your recertification. And Medicare, I know, would not license you to do Medicare cases because they're now penalizing
Right.
for bad outcomes and readmission rates and stuff.
Yeah, and luckily we've been open since 2001, and we've had a great track record so far. And and I really do applaud our staff. Our nurses are so dedicated to safety and infection, and they really are, I would say, the best of the best. And they come and they give it their all. So it's a really great patient experience because you come in and the walk is small to our area. It's just like an office building. And then you come in and it's not as big as a hospital, so it just feels cozier also. And then we hired the happiest staff ever. They're really happy to be there because I'm sure you've been to a place and you could tell the nurse maybe was not having the best day.
Well, I think that's true everywhere. But I got to say, the admission process, since I've had surgery at your surgery center, the admission process is a lot less stressful. The waiting room is a lot less hectic.
Yep.
And I was asleep for the surgery, so I really don't know about that. But it went fine, and I think it's important for that. So let's talk about a couple of other things. First, what kind of procedures do you do?
Yeah, so like we were saying at the beginning, so it's really come along, especially the last, I would say, 15, 20 years. We've seen huge advances in technology. So right now we have an ear, nose, throat guy, an ENT, Dr. LeSueur, but we can do podiatry, we can do general surgery, orthopedic, OB comes in once a month to do OB procedures. And so really...
They don't deliver babies.
They don't deliver babies, luckily.
All right.
That's something we don't want to do.
Well, then they do GYN procedures then.
Right.
Not necessarily obstetric.
Yes,
okay.
Thank you.
All right.
So they do GYN, and we're working on getting a spine doctor from Flagstaff to join us. And what's happened is, you were talking about the advances in technology. 10 years ago, I don't think anybody would say, let's do a fusion in a surgery center. But because of the technology's gotten a lot better, we can. And we're really excited because we're hoping that in a couple months we'll be able to do a total joint procedure. Oh. And so people who aren't familiar with that, that's your knee, your hip, your shoulder, and sometimes now an ankle. And so...
Because you have a podiatrist.
Because we have a podiatrist who can do it.
And orthopedist.
Yeah, and so a lot of times you would go to a hospital and then you would go have the procedure and stay 1 or 2 nights. And what they found is they studied thousands and thousands of outcomes, and they found that people who were able to go to their house had the same outcome, positive outcome, and healing as somebody who stayed in the hospital. Plus, you have 2 nights that you're not paying for. So you're saving Medicare, the system, money, and you're also saving the patient a lot of money also.
Well, and it's a lot more convenient to be at home because you can always have home nursing.
Absolutely, and that's part of it too, is we have home care that we partner with. So it really has come a long way from 1970, when the first day they did 5 procedures by 4 different doctors, and now there's I think 9,200 surgery centers in the country, and each one is accredited, and they have to hit certain standards to stay open.
And there's only certain procedures that are approved for surgical centers versus inpatient. Is that true too?
That is accurate. So
I mean, that makes sense to me, at least.
Yeah. So right now, Medicare last year, they took the total hip. It used to be just inpatient, and now it's on the outpatient procedure. So I think they're starting to say, you know what? We can send somebody to an outpatient facility, and it's going to save us a lot of money, and it's going to have just as good of outcomes. And they're saying to the doctor, they're trusting the doctor to know who's a good candidate for outpatient surgery and who should stay inpatient.
And this is, of course, how it got started back years ago. Is somebody said, well, I can take care of you outside the hospital just as well as inside the hospital if I provide the same type of services. So I think that that's an important consideration for most people, to recognize that somebody along the way has decided that these procedures can be safe outside the hospital, and your recovery, of course, in your own bed the food's probably better too. although some hospitals, have really good food, having been in a few of them. So I think that's an important distinction. I want people to understand one other thing is before we get close, because we're getting close to the time. It goes fast. Who owns surgical centers?
So a lot of times it's the physician, and what we're seeing is it's starting to partner out. So we partnered with a company called AmSurg in 2012, and we did that because we were just our own little entity, and our purchasing power wasn't that great. So when we were trying to buy gauze or needles, we would spend a lot of money. So partnered with AmSurg, now we can buy things at a lot more cheaper pricing, and we can pass that savings on to the consumer. And then local surgeons own ours. So our surgery center is part owned by local surgeons. So they have an incentive to make sure quality is good, patient satisfaction is above normal, because they're owners in it and they're vested in it.
Wow. Now, do you guys have an MRI machine too?
We don't.
You don't? Okay.
Not yet.
Not yet. Okay. All right. Well, that's important. But I think it's important because the disclaimers are required by physicians who own a part of the entities and that. And it's interesting because years ago when surgery centers got started, hospitals thought that they were in direct competition with the hospitals, and so they resisted it. But many larger organizations, hospitals included, are now partnering with surgical centers because it's not a medical issue. It's a convenience issue, as you first indicated. You don't get surgeries bumped as often in an outpatient surgery center, and I think that that's really important. And we're almost out of time, and I really am impressed. Actually, I hadn't thought about some of the things that you discussed about the convenience factor. I knew it was more convenient, but the waiting time, if you're a patient and get bumped for surgeries, that's yucky.
Yeah, it is.
That's yucky. It's because it's really I don't know. It really makes me feel uncomfortable to be waiting, knowing that I'm going to have a surgery. So I'm going to thank you, Brad, for coming in here. Very enlightening and such a good explanation for this. And for our viewers, just another expanse of the medical system, and a safe one. You can see medical care is not an issue at all using surgery centers, and we've had several up here on the mountain, and give them a consideration for whatever your medical needs may be. And I thank you for watching today, and do your best to keep healthy so you don't need a surgical center or even get sick. And thank you very much.